So today's topic is liver function test. It's a short and very meaningful topic because before you see any child with jaundice or any suspected hepatitis, for that matter, on a day-to-day basis also, when you see any LFT report, you should know to interpret it and derive what is going on in the body. So basically, you should understand each component of this liver function test tells different functions of the liver. Although there is no one test which is like perfect to tell that whether liver is functioning right or wrong, the composite of test is what matters. Okay, so let's start the class. So liver, we know, is a metabolic factory of our body. It is a unique organ that has synthetic, biochemical and excretory functions. And there is no single biochemical test that can tell about the global function of the liver. So we use a battery of tests. That means we use multiple tests to detect different types of problem, whether it is a synthetic problem or whether it is a storage problem, or is it the problem in the biliary duct, not liver cells proper. So to detect each component of this, we have battery of tests that is there. But one thing that you have to remember is LFT is neither sensitive nor specific. It just gives you an idea about what might be the probable pathology or pathophysiology going on in liver. It can just give you a probability or possibility of the liver disease. It will never tell you 100% with specificity or sensitivity. Okay, so what remains non-negotiable is good clinical history and a physical examination. After you take the history and examination, only you can correlate with the LFT that is ordered. Okay, so the role of specific disease markers, radiological imaging, and liver biopsy cannot be underestimated. So it ultimately depends on your history taking. Depending on what do you think the differential diagnosis is, what do you think the differential diagnosis is? The imaging, whether you want LFT with the USG abdomen, whether you think that along with LFT you need a liver biopsy is needed. All of this can be taken into a decision. So what is the advantage? The biggest advantage is it is a screening thing. So it's a non-invasive, sensitive screening modality for liver dysfunction. So there are different patterns of disease that can be picked up in one LFT report. You can tell whether it is a hepatitis, that means whether the liver cells are affected. You can tell whether it is cholestasis, that means the biliary tract system is the problem. Or you can always tell whether it is a CLD, that is chronic liver disease. That means the process of damage is not just acute. It's not in weeks. It is going on for months and months. That also can be predicted with one single LFT report. Okay. So it helps in assessing severity and progression of the liver disease and follow-up. Basically in follow-up, if you have given started treatment for any of the disease, like as in autoimmune hepatitis, then to evaluate the response also, the LFT can be used. So what are the limitations? It lacks sensitivity. It lacks specificity, like I told. Sometimes even in a cirrhotic patient, we can get a normal LFT, which the clinical correlation may not be there. Or sometimes in conditions like hepatic fibrosis, where the entire liver cells are replaced with fibrosed materials, but still small amount of liver is enough to compensate for all the functioning. So that's how it can have a normal LFT also. It lacks specificity. Except for serum bile acids, the LFT are non-specific for liver diseases. And serum albumin, which is a very important factor that we use to diagnose chronic liver disease. That means whenever we have a low albumin, the first thing that we keep in our mind is whether this is a chronic liver disease that is ongoing and has been clinically silent. So this albumin can be abnormal in pediatrics, especially in case of PEM, that is your severe acute malnutrition. It can be abnormal in malabsorption syndromes, chronic diarrheas, and renal disorders also. It can be abnormal in many other conditions also, and then may be mistaken for problem in liver disease. So aminotransferases, like I said, SGOT, SGPTs, may not be specific for liver. It will be deranged even in muscular diseases and even cardiac diseases. Correct? So these are the limitations of the liver. Now, what are the functions of the liver? Before we divide LFTs into multiple components, you should know what are the functions of the liver. The main function is metabolic factory. So it helps in carbohydrate, lipid, and protein metabolism. Mineral and vitamins are stored in liver. Like we all know, vitamin A, D, E, K, that is all your fat soluble vitamins are stored in liver. When it comes to storage, along with vitamins, it is also glycogen storage disorders can present with LFT problems. Iron deposition also is happening in iron storage also happens in liver, correct? And the excretory function is the bile excretion. Okay, and then we have something called as protective function, that is Kupffer cells act like APCs, antigen presenting cells, helping the liver to participate in your immunity also, and it also performs phagocytosis. And when it comes to synthetic function, it helps in production of proteins as well as clotting factors. And then you have detoxification. That means if you have any drugs being taken, for that matter, the simple paracetamol also gets metabolized in liver through cytochrome enzyme. So these are your broad functions of the liver. And then we divide the LFTs also based on this. So if there is transport problem, if there is transport of organic anions and drug metabolism problem, then we usually look for serum bilirubin, urine bilirubin, and urobilinogen. If there is synthetic function or the hepatocytes, that means the liver cells are injured, then we start getting rise in aminotransferases, that is rise in liver enzymes, that is SGOT, SGPT, alkaline phosphatase, and even GGT, that is glutamyl transpeptidase, which is almost nearly specific for your bile duct. And then we have other functions like biosynthetic capacities, like your serum protein, albumin, pre-albumin, prothrombin, all of this. And sometimes we also do something called as clearance test. That means clearance of a substance from the plasma by liver also can be tested to see whether liver is able to clear and if the liver is having a active cytochrome oxidases or no. So broadly, you should remember in these headings. Okay. Now, what are the tests of anionic transport and drug metabolism? So that is, the first is bilirubin. So we know that normal bilirubin is always below 2, and whenever it is increased, you got something called as jaundice, correct? There are 4 different forms of bilirubin. First one is the unconjugated form. Now, unconjugated bilirubin is tightly bound to albumin. Okay, it is lipid soluble and it is not seen in the urine. Then this is carried to the liver where it gets conjugated. So now this benefit of getting conjugated is it becomes water soluble and gets easily excreted in urine. Then there is something called as delta bilirubin. Now delta bilirubin is covalently bound to albumin. So that means if we have very high bilirubin levels in any child, some percentage of it will be in the form of delta bilirubin. Now delta bilirubin and unconjugated bilirubin, how is it different? Unconjugated bilirubin is only tightly bound to albumin, whereas delta bilirubin is covalently bound. That means for it to become detached from albumin, your bilirubin level should be very low and the covalent bond has to be broken. This takes a longer time. So the half-life of delta bilirubin can be as high as 14 to 21 days, especially in babies who require exchange transfusion and all. There can be ongoing problems because of the high levels of delta bilirubin. Okay, it helps in, it causes delay in resolution of jaundice. The last one is the free bilirubin or unbound bilirubin because it crosses the cell membrane, and this is the one responsible for bind. That is bilirubin induced neurodysfunction, which in a chronic, which in a long time is called referred to as kernicterus. Okay, so these are the 4 different forms of bilirubin that you all should be knowing. There's a word called direct bilirubin, which is actually the conjugated bilirubin plus delta bilirubin. Okay, so you should know all of this. These are all important for your NEET PG also. The second important component of anionic transport or drug metabolism is urine bilirubin. Now, presence of urine bilirubin basically tells that there is a ongoing hepatobiliary disease. That means the bilirubin levels are so high that it is even getting excreted in the urine. And conjugated bilirubin in urine, say like I said in the last slide, the only bilirubin which is excreted in the urine is conjugated bilirubin. So it can be an early sign of acute hepatitis that even before the complete jaundice comes in picture, you can have urine bilirubin positive in the child. Okay. The third is urobilinogen. Now, urobilinogen is also checked in urine. This is a very sensitive indicator of hepatocellular dysfunction. That means early hepatitis. So, if there is hepatic cells injury, you can have high urobilinogen in urine. In case of biliary obstruction also, you can have urobilinogen excretion, but it will be very less, very less. Why? Because of the biliary obstruction, it is not getting excreted into the gut from where it should ideally be absorbed in the blood and then excreted in the urine. So whenever you have increase in urobilinogen, it is a sign of hepatocellular dysfunction. Whenever it is low urine bilinogen, very low, then it should be a sign of biliary obstruction. So that is your first three components. The next subheading is hepatocyte injury. That means whenever hepatic cells are lysed. So the moment they are lysed, the enzymes in them is poured out into the blood, leading to rise in ALT and ASTs, which are nothing but the liver enzymes. Now, ALT, or also called as SGPT, is very specific to liver. So how do we remember that? L for liver. So ALT is very specific for liver, whereas AST, so AST may be found in multiple places like liver, skeletal muscle, kidney, and other areas. That is why this is not very specific. And one more thing that you have to remember is the ALT is a cytosolic enzyme. That means it is present only in the cytosol, whereas AST is a both mitochondrial and cytosolic enzymes. That is why whenever there is liver injury, you can have very high AST levels and just mildly elevated ALT levels. Okay, so this can be a major difference in many of the illnesses that we'll be discussing later on in the next lectures. Okay, then there is the causes. So what are the causes of raised liver enzymes? So whenever you have ALT more than AST, so to call it as elevated, it should be more than 5 times the normal. Okay. So whenever you want to tell that there is chronic or mild elevation of the ALT enzymes, first, the moment ALT is more than AST, you have to think of hepatic causes like autoimmune hepatitis, chronic hepatitis, medications, steatohepatitis, Wilson's disease, and non-hepatic causes are hyperthyroidism and celiac. Whenever there is severe or acute elevations, that is more than thousands, then you should think of a acute cause. So acute viral hepatitis, which can decompensate to encephalopathy, or acute Budd-Chiari syndrome. There is a big venous thrombus sitting in the portal vein system leading to Budd-Chiari syndrome. Then you can have a very high elevated ALT levels. Also, hepatic artery ligation, ischemic hepatitis, and sometimes drugs and toxins also can give rise to acute elevations. You need not rectify all of this. Each one of this will be discussed in the upcoming lectures. Okay. So how do we correlate these both enzymes? AST and ALT ratio is one very helpful thing that is taken for help. So that means whenever ALT is more, that means this ratio will be less than 1. So that becomes more specific for liver. So viral hepatitis, toxic hepatitis, autoimmune hepatitis, if there is a cholestatic hepatitis or NASH, that is non-alcoholic steatohepatitis, then you generally get ALT more than AST and thereby the ratio being less than 1. Whereas whenever you have rise in AST very high, then you should think of some systemic symptoms. That means some systemic disease like as in Wilson's disease or some cause giving rise to chronic liver disease. It's an ongoing problem. That is why both cytosol as well as mitochondria both are affected, leading to outpouring of AST. Okay, and alcoholic hepatitis because alcohol affects every cell of the body. So AST from every other cells of the body is also poured out into the blood, giving rise to a very high AST levels. And even shock can give rise to a very high AST levels. So that's a simple way of remembering when to suspect what disease. So if you have a very high ALT, you will think of more hepatic causes. Whereas when you have a very high AST, think of systemic disorders. Systemic disorders like Wilson's disease, alcoholic hepatitis, some chronic cirrhosis, like in your hemochromatosis, other causes, whichever have systemic symptoms. So that's how you remember it. So AST, platelet ratio index, called as APRI, is also used. Now APRI is basically used to diagnose moderate to severe fibrosis. So you should basically know this new index called as APRI, that is AST platelet ratio index. Okay. Next is enzymes for cholestasis. So we all know the enzymes for cholestasis is alkaline phosphatase and GGT. So alkaline phosphatase is a non-specific enzyme because it is present in multiple other places, like it is already written that kidney, bone, intestines, they all can have ALP. So it can even be high in newborns because of the metabolic bone disease. So just bone problems, kidney problems also can raise ALP levels. So it is relatively non-specific only for cholestasis. It can be high in childhood because there is growth spurt leading to more bone deposition, giving rise to high ALP. And whenever it is Wilson's disease, the ALP bilirubin ratio also is taken less than 4. And whenever it is drug-induced cholestasis, that time also ALT-ALP ratio has been taken. This we'll discuss later. Okay. So these are your causes of high and low alkaline phosphatase levels. So high alkaline phosphatase levels can be seen even in bone problems, bone metastasis, amyloidosis, granulomatous liver disease, mainly cholestasis. Okay, low alkaline levels can be seen in hypothyroidism, zinc deficiency and congenital hypophosphatemia. Okay. So what is GGT? Now, gamma glutamyl transpeptidase is relatively more specific for liver as compared to ALP. It is not found in bone, so bone diseases can be easily excluded whenever you have high GGT levels. Okay, so these are your normal ranges. Roughly to remember, you should know that till 1 month, it should be below 500. And after 1 month, it should be below 300. So this is how you grossly remember it. So these are your causes. So all your high GGT causes are your cholestasis causes. All your causes of neonatal cholestasis can be your causes of high GGT. But low GGT, only 2 causes are there. One is PFIC, that is progressive fibrosing intrahepatic cholestasis. BRIC is the benign recurrent intrahepatic cholestasis. Both of these have more genetic basis. So this I have mentioned it only for your MCQ purpose, that you should be able to identify that whenever there is low GGT, the causes are PFIC and BRIC. Okay. Next, coming to the third enzyme of cholestasis, that is 5' nucleotidase. Now, 5' nucleotidase is found in liver, intestine, brain, heart, and other tissues, but again not found in bone. So, marked elevations are seen only with underlying liver disease. Otherwise, not much of importance. The fourth enzyme is, this is only for the sake of completion, that is leucine aminopeptidases, which is a zinc-dependent exopeptidase. This is also raised in cirrhosis and cholestasis. So more liver specific, but still not much under use because it is still not widely accepted. Next, coming to the biosynthetic activity. So synthetic functions you check by albumin. So liver is the site of all plasma protein production. So whenever there is low albumin, it says that the liver is affected, and also says that it is affected for at least more than 3 weeks, because the half-life of albumin is around 21 days. The moment you see hypoalbuminemia, it says that it is a sign of chronic liver disease, at least the ongoing problem for more than 3 to 4 weeks. So that's the most important carry home message of this slide, that if it is less than 3.5, you should think in terms of chronic liver disease. It can be normal in hepatitis, drug-induced hepatotoxicity, and other cholestasis measures. Okay. Autoimmune hepatitis also, there is one thing, that because autoimmune is again antibody production, antibodies are predominantly globulins. there will be reversal of AG ratio. So whenever you have reversal of AG ratio, that time also you should suspect that there is autoimmune hepatitis. Okay. So the second point is PT, APTT, INR. That is your coagulation profile. Now PT is the sign of extrinsic pathway. Correct? PT is small. So extrinsic pathway is small. It tells about the extrinsic pathway of coagulation. Whereas APTT is long, intrinsic pathway is long. So it tells you about intrinsic pathway. That means all the factors involved in intrinsic pathway is represented by APTT test. All the factors involved in extrinsic pathway is represented by PT. So the PT basic also the factors that is 2, 5, 7 and 10. Okay. All of this are produced in liver. So whenever there is acute liver dysfunction, automatically PT, APTT will get prolonged because these production of these factors are affected. Also in cholestasis, even with the normal hepatocytes, because there is decreased bile salts and decreased absorption of vitamin K, you can still have raised APTT because vitamin K dependent factors are also affected. And these are the same again vitamin K dependent factors. Okay. So yeah. So this is the prothrombin type. Sorry, this is 2, 7, 9, 10 is your vitamin K dependent factor. 2, 5, 7, 10 is produced in the liver. Okay. 2, 7, 9, 10 is vitamin K dependent. Okay. So PT returns to normal or improves by at least 30% within 24 hours of single parenteral injection of vitamin K1, which is around 5 to 10 mg that we give. It indicates that there is a good liver parenchymal function. That is why in hepatitis or hepatic cell failure, what do we do is we give one vitamin K and 12 hours later, we repeat a PT, APT, INR. So if it is normalizing, that means the liver is still able to produce it well. So sign of good liver function. So based on this, we have definition of acute liver failure. So when do we call it as acute liver failure? Even without symptoms, it is without encephalopathy, that is without any symptoms. If the INR is more than 2, then we call it as liver failure. Or if the INR is more than 1.5 with the symptoms, then also it is defined as acute liver failure. So a persistently abnormal prothrombin time in a previously well child can be a single lab test that can predict the possibility of development of acute liver failure. So normal INR till 1.2 is accepted. Anything beyond 1.2 needs to be under close observation. So these two are the tests of biosynthetic activity, albumin and prothrombin time, or in short, the coagulation profile. Okay. So test based on substances cleared from plasma by the liver. We all know ammonia clearance, correct? So ammonia is also cleared. It forms urea and is getting excreted further in your urine. So the liver ordinarily removes 80% of the portal venous ammonia in a single pass. In chronic liver disease, ammonia level goes on increasing. In fact, this is hyperammonemia, which is the cause of encephalopathy in case of chronic liver disease. And even in urea cycle disorders of newborns, where the child will be encephalopathic because ammonia levels will be very high. So in newborns, ammonia levels of more than 300 is taken as a definitive sign of urea cycle disorder. More than 100 is definitely abnormal. 100 to 300 is a gray area which can be the diagnosis like transient hyperammonemia of newborn or transient metabolic problems giving rise to hyperammonemia. May not be a sign of urea cycle disorder. Okay, but more than 100 is definitely abnormal. So these are just for your exercise that you should know to interpret them. So if a 9-year-old child comes with vomiting and jaundice for 2 weeks and there is soft, tender liver, okay, 4 centimeters big, spleen is not palpable, there is no ascites, okay, but definitely a tender, soft liver with vomiting and jaundice, So the first probable differential diagnosis that we'll have is, anybody wants to answer? Okay, so probably with the clinical history of vomiting, jaundice, and your soft tender liver, first differential diagnosis would be a hepatitis, correct? So when we do a LFT, this is how it has appeared. So definitely there is jaundice and there is direct hyperbilirubinemia, and ALT, AST both are raised. ALT raised more than AST probably, correct? Albumin is normal. So definitely this is not a chronic problem. It's an acute problem. Correct? PT, APTT, INR look okay. GTT also looks okay. So probably we are dealing with the acute hepatitis, that is your hepatocellular pattern of injury, most commonly being acute hepatitis or a autoimmune hepatitis. Correct? So this is your second case. So if the same child came with a deranged PT-APTT-INR, you give vitamin K, and after 8 hours of vitamin K, when you repeat the INR, it is still high. Okay, and albumin is still normal. So what do you want to suspect here? So it is acute liver failure. Why? Because without the symptoms also, INR is more than 2. So it can, the cause of acute liver failure can be drug induced or a hepatitis induced fulminant hepatitis leading to hepatic failure. Correct? So next, coming to one case 3. These cases are kept so that just you interpret the LF and come to a differential diagnosis, or at least a broad heading of what the liver problem looks like. 2-month-old child coming with jaundice since birth, and there is clay colored stool. There is a dark urine, saying that it is cholestasis. Whenever there is cholestasis, stool color will be clay colored. Correct? There is a firm liver, span of 7 centimeters, mildly increased. Spleen is also palpable. There is no free fluid, but these are your LFT. Total bilirubin is 10.4, direct is 8.7. ALT is raised. Liver specific enzymes are raised. Albumin is still normal. GGT is raised. Now this should ring the bell. GGT is raised, saying that it is the biliary tract which is the problem. INR is still okay, saying that it is not the synthetic function. It looks more like a cholestatic function. That means your bile duct injury. That is your cholestatic pattern of injury. So either it is an extrahepatic biliary duct obstruction or it is a PFIC, that is progressive familial intrahepatic cholestasis. Correct? Then is your last case. So this is your 8-year-old child with jaundice noted from 2 weeks again. Liver is firm, 4 centimeter. Spleen is also palpable. Now there is ascites also. So signs of free fluid is also there. And then you have total bilirubin raised. You have ALT, AST, which are fairly okay. Didn't expect this, right? So just fairly okay. Albumin is low. Tells what? That it is a chronic problem. Okay. Along with that, ALP is raised. Again, saying that it is a bile duct problems. Plus INR is deranged, saying that the liver is decompensating. Probably if we don't treat it now, the child will come in encephalopathy. So it is a chronic problem. So probably a differentials of chronic liver disease you should think. And INR is deranged, saying that it is decompensated. So this is a case of decompensated chronic liver disease, differentials being Wilson's, hepatitis B, C, and others. Okay. So this is your last case. It is a 10-year-old boy coming with jaundice of 7 days. There is some family history of, I think the diagnosis is visible. Huh? Okay, fine. So the family history of liver disease is there. Plus there is cognitive decline. That means it is not just liver, early CNS symptoms also have started. It can be whenever there is cognitive decline, either it is encephalopathy or some other CNS involvement. Correct? So there is liver, there is spleen, but there is no ascites. Cola colored urine is They're saying that there is some amount of hemolysis going on. So now you should connect the links. So there is liver problem, plus there is hemolysis, plus there is cognitive decline, that is CNS symptoms. So classic of your Wilson's. Okay. So like expected, hemoglobin is less, INR is deranged, albumin is also on the lower side, saying that it is a chronic problem that is going on. And like I told, AST is more raised, saying that it is a systemic problem. It is not a liver specific problem. It is a systemic problem. So in Wilson's disease, we have something called as Coombs negative hemolytic anemia. That means even if the DCT is negative, you can still have hemolytic anemia in Wilson's. So there is Coombs negative hemolytic anemia plus CNS involvement because your copper deposition happens even in your CNS. So after some days, this cognitive decline will also become flapping tremors. So you can even see flapping tremors, cognitive decline. Sometimes the earliest symptom with which the patient comes to us with the poor scholastic performance, previously doing well in school, suddenly is not getting good grades. And then when we do a thorough examination, we pick up all these flapping tremors and things, and the LFT will show raised ASTs and lower albumin, thereby picking up Wilson's disease. Now here, this is a case of fulminant Wilson's because all enzymes are raised plus severe hemolysis with your raised bilirubin is there. So this is how a Wilson's or a systemic problem can present to you. So this is how you will correlate different types of hepatocellular injury. At the end of the class, I want you to remember that whenever enzymes are raised, you think of hepatitis picture. Whenever INR is raised and doesn't get corrected with vitamin K, you think of acute liver failure. Whenever there is a rise in ALT or GGT, you think in terms of cholestatic pattern. And when you have low albumin, you should always think in terms of chronic liver disease plus raised AST along with other systemic symptoms like blood, hematopoietic or CNS. Then you should think of systemic disease, most commonly the Wilson's disease. So I think today's was a short class. I kept it very simple so that you go back and read the LFT and you understand from the class. Okay. So any doubts? Any doubts, you can always write to my mail. This is my mail address. So you can always write